All right, so this is an old statistic, but it's the one that's still in your book, because the Institute of Medicine, now they're called the National Academy of Science, really monitors healthcare. What they found out when they did a survey, did y'all always think that a hospital was the safest place that you could be in the world, all snuggled in safe in a hospital? You know, now we're finding out that errors happen in hospitals. Do y'all see that up there? The 8th leading cause of death in the country is medical errors. Now that's just not medication errors, but medication errors are a type of errors that happen in the hospital. That's more than breast cancer, more than HIV, and more than motor vehicle accidents that take people's lives. So that's scary, isn't it? So we really need to be good at what we do in giving medication. It's estimated that about 44,000 to 90-something people, 90-something thousand people die every year, and that's not on the test, but she's scaring you, as a result of medication errors. Another thing that happens in the hospital are ADEs, or adverse drug events. They're unexpected things that happen from medication administration. And a lot of those are preventable. And look at some of and you won't ever have to know costs, but that should be astounding to you. But look at the medication errors. Why do they happen? Nurses not familiar with the medicine they're given. We'll talk about that. Failure to recheck. Ooh, we're going to recheck so many times, y'all are going to be tired of rechecking. We're going to recheck and recheck and recheck. Workload. I think nurses are busy and have a lot of patients. Distraction at work. Miscommunication. Mistakes with verbal orders. Yeah. Do y'all remember not too long ago in the news that I always say her name wrong. Redonda Voigt. That was the nurse at Vanderbilt that made a medication error that caused her patient to die from that error. And it was really based on workload and overriding a medication system, like doing a workaround. And she reported it immediately. She reported that an error was made immediately. I think Vanderbilt kind of threw her under the bus. She ended up losing her license and everything. But I'm going to post a video about that in the course after we talk today, and y'all can look at that and see what happened with her. But she overrode a medication system and ended up in the death of the patient. She was just kind of a floater that day. She had somebody with her on orientations in a hurry and did a workaround. So the Joint Commission, we've talked about a good deal, and they're the ones that, are all about safety. National Patient Safety Goals since 2002. And one of the goals since 2002 has been making sure that you give medication safely. All right. So think about the biggest hospital you know. Huge. Mobile Infirmary is huge. South is huge. We have 3 hospitals, plus a cancer center. And think about all the things that have to happen to get the medication to your patient. There's so many steps. And when there are so many steps involved, what can happen? Mistakes can happen. So the prescriber writes the order. Who is the prescriber? The healthcare provider, which can be a physician, it can be a nurse practitioner, a PA. They write the order. Either they write it on paper, if all the computers are down, or it's an extended care or something like that, or they type it into the computer. There's step 1. Step 2. Well, could be the nurse that reviews it, but that, if it's electronic, it goes straight to pharmacy. And the pharmacist has to check it and make sure that the order is good. On the electronic health record, it pops up to the nurse that there's a new order. And she or he has to validate that and say the order is good. So it goes through all these steps. And when I say the order is good, what does that mean? That,
It's safe.
it's safe. Like, is it a safe dose that's been ordered? Is it a drug that's even indicated for the condition that it's been ordered for?
Are they allergic?
Are they allergic? Are all parts of the medical order there? Like, there has to be all of the parts, and we're going to talk about every single part in just a second. And then it has to go, the medication has to get up to you from wherever it's going to come from. And we'll talk about all the places that it can come from. And so, and then the nurse will be given the medicine. So there are so many steps in this process, and there's room for a mistake at every step. And so, fortunately, I think, because I think nurses are awesome, we're the final step. We are the final step before it goes into that patient. So we're the gatekeeper, really, of this medication process. Here they are. Here's how you cannot mess up, hopefully. Okay? These are what we call the 7 rights of medication administration. Do you need to know these?
Yes.
You do. Like the back of your hand. And y'all, I'm going to tell you something. If you will follow these 7 rights every single time during your career when you give medicine, I don't think you're going to make a medication error. And if you do ever make a medication error, you're going to want to throw up. And then if you throw up a lot, what kind of acid base is that? Right? What kind? Metabolic alkalosis. It really literally will make you sick if you ever make a mistake. But the goal is to report it, right? So we're gonna go over these 7 rights right now. Let's do it. Y'all already know how to do this. Jaguar J. Jones. Jaguar J. Jones. Medical record 4176352. Medical record 4176352. Date of birth 8/25/1963. It all matches, and that's really true because I've said it 10,000 times. So how many identifiers? 2. 2 identifiers. Now, how does a patient get that armband on? There's an admission process. So those people are responsible for getting that armband on that patient. Now, y'all, what if you've been taking care of that same patient for a long time? You still check that. This is probably the main reason for medication errors. The wrong patient gets the drug. The nurse gets what? Distracted, busy, not thinking. So ask somebody else to do something. So we're gonna, and you have to compare it to the chart every single time. Every time. Or not really the chart in this case, it's the MAR. Y'all know what that stands for? Medication Administration Record. So when you look at a health record, you'll see the orders. Like y'all saw the doctor's orders when you did your care plan. Hopefully you saw the list of orders. Well, those are transcribed or taken from that and put on another document called the MAR, and that's what you give your medicines off of. All the patient's medicines are on that MAR. So you're going to be comparing the MAR with this patient. Okay, so 2 identifiers, and we're going to compare it with the armband, and we're also going to do what?
Check for allergies.
We're going to check for allergies, and we're going to ask the patient if there are any additional allergies that we need to know about, okay? Really important. Do healthcare providers ever order medicines that the patient's allergic to?
Yes.
Yes, they do. And who catches it? You do. There are physicians that say, you know what, I can't tell you how many times a nurse has saved my honey, you know, because we're checking and double checking. What if the patient's all swollen up and they don't have an armband on? We got to get one. You know, you can connect those things and put a bunch of them on it. The armband has to be on the patient. What about taping it to the bed? Have I seen that? You've probably seen it maybe if you work in a hospital, yeah, but what about those beds?
They don't go with the patient.
They don't, we move patients in and out of beds all the time. Like USA, the big house, or medical center, or whatever you wanna call it, they just got new beds for everybody in the hospital. And I went over there that day and was helping move patients from bed to the new bed. And what if their armband had been on that bed? You know what I'm saying? So beds, we change beds all the time, so it has to be on the patient. What if it gets smudged, or you can't read it, or whatever? You get a new one. You get a new one, really important. What about asking the patient to stay? Some of y'all, when you did your checkoff, you said, can you tell me your name and birthday? Is that okay to ask them? It's okay to ask them, but is that one of your two identifiers? No. Because some people with dementia, I'll say, you know, I'll say, are you Deborah Swansea? I sure am. Or, you know, what if they can't hear and they say they don't answer your question correctly? That is not an identifier. It's a third identifier. It's considered a third identifier, but it's not one of your two, okay? Okay, y'all have probably seen these if you work in a hospital. So in addition to looking at the name and the date of birth or the medical record number, whatever your hospital says, there's a barcode system as well, where if I'm about to give medicine, typically what happens is on my badge, there's a barcode. I'm going to scan my badge. Beep. I'm going to scan the medication. Beep. And then I'm going to scan the patient. Beep. And your patient's stuff, medication, MAR stuff comes up, and it helps. It's another check and balance to make sure you've got the right patient, the right drug, etc. So every hospital had pretty much. Why do you think we had to go to this?
Because of all the errors.
Because of all the errors. Yeah. This is just another safeguard, hopefully trying to keep the errors from not happening. But are there workarounds to this? There are. Should we ever participate in workarounds? We really shouldn't. We don't use the room number because patients move from room to room too, right? So we don't use that. Now, some of you may work in a long-term care facility. They have a little bit of different rules sometimes, but we're not long-term care. We're talking about acute care facilities like a hospital, and this is the rule. You don't use the room number, you don't use what they say or anything. We already talked about all that already. Right one, right patient. This one takes a while. Right drug or right medication. Let me ask you this. Do you think there's any critical thinking involved at all in medication administration?
Yes.
Yeah. Did you see one of the reasons for medication errors is that the nurse probably didn't know what drug they were given, and they just saw it on the doctor's orders and tore in there and gave it? Scary. Because what if I'm giving a blood pressure medicine? I don't know what it is. It's ordered. I'm going to go give it. And I didn't bother to check the patient's blood pressure, and it's already 70 systolic. And then I go in there and I give them their blood pressure medicine. Is that okay? I mean, it was ordered. Am I covered because it was ordered that I went in there and gave it? No, you have to have clinical judgment at all times when you're giving medicines. Just because it's ordered doesn't mean you have to give it, okay? I mean, you have to give it if it's indicated and it's time for it, it's an antibiotic and all that. But if in your clinical judgment you're saying, I need to hold this and you always have to let somebody know, let the healthcare provider know, I'm holding this right now. You have to know what you're giving. And there is a lot of judgment involved. If you're giving insulin or whatever, and the breakfast trays are late, well, you're supposed to give it at a certain time, but maybe I need to hold it because the breakfast trays aren't up here yet, and I don't want to cause my patient's blood sugar to tank. So there's a lot of thinking and judgment involved in giving medicines, and one of them is you need to know what you're giving. You have to know what you're giving and why you're giving it. So we talked about that. What it means by is an order valid, it has to have all the parts. Like, does it have is it on the patient's chart? Is the drug listed? Is the dose listed? Is the route listed? Is the time listed? It has to have every part of that order. And again, before you give it, you may have to look at labs. Like we talked about blood pressure, but do y'all know what a diuretic is? It makes you pee. Well, when you give people diuretics, they pee out a lot of their potassium. So maybe before I give the diuretic, it's never going to be on the chart. Hey, Deborah, go check the potassium before you give that diuretic. I just know. So you have to know what labs to check. Maybe I'm checking a level of vancomycin or some big antibiotic I'm giving, and I want to make sure that I'm not giving them something that's toxic. Or maybe I want to check their kidney studies before I give something that's nephrotoxic. So there's a lot of thinking involved before you give medicine. If I'm giving somebody a blood thinner, maybe I need to check their coagulation studies before I give it, right? Just don't tear in there and give stuff, right? Don't do it. Okay. Medications are classified. And y'all aren't taking pharmacology. Y'all are the first group that's not taking pharmacology. So let me tell you something. They're classified by what they do. Like there may be medicines that are ACE inhibitors and they're for blood pressure and they do certain things. Beta blockers do certain things. Analgesics do certain things. And some of them are classified in lots of columns, like aspirin. It's an analgesic, it relieves pain. It's an antipyretic, it brings your fever down. And it's an anti-inflammatory that helps with the inflammatory process. So we classify medications by what they do, but know that some medications, like aspirin, can do several different things. And so you really do need to know why your patient's getting what indication it is. Okay, y'all are not in pharmacology, so this is new to you. So I do need you to know what these terms mean, okay? You need to know this is called pharmacokinetics, and there are 4 steps of it. The first step of giving a medicine is absorption. That means that you're giving it from whatever route, whatever place it begins, how quick it gets into the bloodstream, okay? It's how the medication gets into the blood. So what do you think is going to get into the blood faster?
IV.
IV. What's going to be kind of slow?
By mouth.
By mouth. What do we say by mouth? What's the medical? PO. Very good. So, and also absorption is going to be affected by, well, certainly the route, the blood flow to the area, maybe not the dosage, the blood flow to the area, the route, the lipid solubility of the medication, etc. So that's absorption, how fast it gets into the bloodstream. So do you think if you give somebody something IV, you have a lot of time to correct it?
No.
It's in, it's gone. Okay, that's why IV medications are kind of scary sometimes to give. The next thing is distribution. It gets to the site of action. Getting it to the site of action. And that has a lot to do with blood flow as well. And this is an important concept to think about for old people or older people. Medication binds to albumin, which is a protein. Y'all remember that from pharmacology. And only the medication that's free and out there that's not bound to albumin is going to be used. So older people, they have decreased protein. You know, y'all know that? They have decreased protein a little bit. Their nutrition's not always the same. And so they're going to have more free medication in their circulation. So what does that tell you about dosages for older people? They need to be smaller usually.
Less is more.
Less less medication for older people, they can become toxic quicker because their albumin levels are lower. And we need to be thinking about all these things as nurses, you know. Maybe, hey, this lady is 99 years old, healthcare provider, you think we might need a different dose? Is that okay for us to ask?
Yeah.
Yeah, I mean, nurses say tinies all the time. And then metabolism, that medication has to be broken down into a less active form. And that happens in the kidneys, and it happens in the liver, etc. So what do you think about somebody with kidney disease? They could become toxic on certain medications, okay? And then excretion is the medication leaving the body. And we can excrete medication in sweat, in stool, in urine, respiratory-wise. So all important to think about. Think about this. If a medication you're giving a patient is absorbed when it gets into the intestine and the person has diarrhea, are they getting that medication? No. And you as a nurse would need to be aware of that. Let somebody know. So make sure you know what all these pharmacokinetic things mean, okay? Y'all, we're still on the right medication. Now, medications can have all kinds of actions. A therapeutic action is what we want. That's what we're hoping for. If I give somebody aspirin because they're hurting, I want it to decrease their pain. A side effect, I'm sure you know what a side effect is something that we kind of know is probably going to happen or might happen when somebody takes this medicine. It doesn't take us by surprise. We know that sometimes the medication's going to make you nauseated, or you know, you might get sunburned if you go out in the sun, if you're taking certain antibiotics, or it may give you diarrhea, it may turn your urine a different color. We expect these things, okay? And we have to weigh the risk versus the benefits. This is what I've already said at the very beginning. It's an undesirable effect of a medication, something we didn't expect. An ADE, adverse drug event. I don't care that you know the definition of pharmacodynamics, but as a nurse, we need to know how medications work. Sometimes we do plasma levels of medications. So a peak plasma level is when the medication is at its highest, most therapeutic level, and a trough is where it's at its lowest. What do you need to know about that? Let me tell you what you need to know. Sometimes certain medications, typically antibiotics, will draw labs. And y'all know what I mean by drawing labs. Mr. Sherdell and I were talking about this earlier. You're going to stick a needle in my arm and draw blood. Sometimes we draw trough levels, peak and trough levels of medications like antibiotics. So trough level is where the medicine's at its lowest. We draw that 30 minutes before you give the dose. A trough level is typically drawn 30 minutes before you give the dose of the medication. And then you'll draw a peak level whenever that medication is expected to be at a peak, and that's just dependent on whatever type of medication it is. So if I drew a trough level and it was really screaming high, and it was really supposed to be at its lowest because I drew a trough, do you think I might have to adjust the dose? Yeah, might have to adjust the dose or check their kidney studies or whatever. This is talking about ADEs again. A lot of our drugs that we give have black box warnings on them. That means that you need to be super careful giving this medication because it may produce lethal effects. There are many medicines we give that have big warnings on them, but we still give them. But we're watching these patients very closely for certain conditions, okay? Certain medicines I know what I'm watching for, and you will too. And if we do have an ADE, it's reported. You can become toxic on medication. Sometimes you can take a medication for so long, you can become tolerant of that medication. Like I've been taking this certain drug, not me, I've been taking a certain drug for years, and suddenly it's not effective. And so then they have to increase my dose because I've become tolerant on that medication. I love this word, idiosyncratic reaction. What that means is the medication is acting weird, not like it was supposed to. One of the ones that comes to my mind is the medication we give for anxiety, like Ativan. And what it does sometimes is instead of relaxing the person and causes them to calm down, it has the very opposite effect, and they go kind of bonkers. So that would be an idiosyncratic reaction. It didn't do what it was supposed to do. Sometimes medications interact with each other. So you know you need to teach your patients, always check with your healthcare provider before adding anything to your medication regimen. And that includes over-the-counter drugs, right? And then sometimes we know that drugs are going to work together. And we love it, like blood pressure medicine. We may combine several different types, like a diuretic, an ACE inhibitor, something else, because we know that they're going to interact together with positive effects. So if you don't know in the hospital whether medications are compatible or working together, etc., what do you think you would do? You would look it up. In the hospital, there's always, on the computer, you can look up the medications, you can pull up the drug book, and it's your responsibility. And you can always call the pharmacy too. You can have an allergic reaction. You're exposed to this medication once, an antigen happens, and the next time they get that medicine, they got a full-blown allergic reaction. And they can be various levels, which I talked about allergy reactions in pathophysiology with Dr. Wright. We already talked about tolerance. Some people don't use their medicines like they're supposed to. And then there's dependence that we used to call addiction. There's a psychological dependence that the people want that medicine for something other than what it's intended for. And there's an actual physiological dependence, meaning that if they don't get that drug, they actually have withdrawal symptoms. So just some things to think about with medicines. Medicines many times sound alike and look alike. When you get to a hospital, many times there are going to be posters around, be careful of this drug, it sounds like this drug. I always tell the story. Y'all know who Dennis Quaid is? Does anybody know who Dennis Quaid is? Do y'all remember the Parent Trap? The daddy. He had twins, and they were getting heparin, and the nurses, I guess, were not reading the vial. They were just going by the color of the label. And those twins were getting like 2 or 3 times more of heparin dose, which is a blood thinner, than they needed. So y'all, I think they ended up being okay, but it was awful. So the moral of the story is, y'all need to know who Dennis Quaid is, and you don't go by the color of a label. Even though many things are color-coded, you still read the label. A lot of drugs do sound very much alike, very much alike. In fact, when you read labels sometimes, they're so close that they have tall man, short man writing. Do y'all know what that means? Like amlodipine is a medicine, and it may have a big A, a big M, little L, tall man, short man lettering to draw your attention to that. You'll see that frequently. So what do I want to tell you here? Okay. Yeah, y'all be sure that you make sure you know that there's a look-alike, sound-alike list posted. Medication reconciliation, what that means, y'all, we're still on right medicine. Anytime a patient moves anywhere, from ER to the floor to ICU back to the floor to the rehab, wherever, medication reconciliation has to happen. Many times it's done by nurses. Are they supposed to be on all these meds? Are there any duplicates? Are the doses right? go through all the orders, and you reconcile that every time they move. And you do it when they come in the hospital too, with that grocery sack of medicine, making sure that you see that they're taking what's ordered. Many times people will hold on to medicines for years, and it's a mess. Okay, now here's where we really get serious about us. Your checkoff for this. Your checkoff for this, y'all, is at home, recorded by you. You're going to record yourself doing this one and upload a link to a video. And so this is one of the things that you'll do, okay? The very first thing that you do and a nurse will do is this. You got to verify the order that it's right. So the person wrote the order, and it's going to pop up on the electronic health record. And the nurse has to say, before that medicine's given, the nurse has to say, I verify that this order is correct. That means that you looked at the original healthcare provider's order, and you looked at what has been transcribed to that MAR, and it matches sort of. Is that all right? It matches sort of, kind of? It has to match exactly. Has to be the right drug spelled, it has to be all the parts, it has to match exactly. And so that's the first thing that you're going to do as part of your checkoff and as far as nursing. And this is just for a new order. Once Deborah Swansea says, yeah, that order's good, I verify that it's right, now every nurse after me, that order's on the MAR, and they just give it. They just give it, because Deborah Swansea validated it. Ooh, that's a mess, isn't it, if I was wrong? So, once it's been verified, it's good to go as an order that people will continue to give until it is discontinued. So that's the first step. We're going to verify all new orders. Now, here come the 3 safety checks. Do you think that's going to be on your exam? It is. And it's also going to be on your checkoff sheet. I mean, y'all look at me and get this straight, because students always mess this up. That verification of a new order is not one of these 3 checks. It is not. That's just saying, yeah, that order's good. But that's not one of the 3 checks of you going and actually giving this to the patient. Okay, here come your 3 checks. Right here. And when I say 3 checks, are you pretending like to read the label and just looking at the color of the label? Or what color the medicine is? No. So here's what we do. When you get it, the medicine out of wherever it is, and I'm going to show you some pictures of where medicines are sometimes. When you pick it up, you read it, and that's the first check. And this is, say this is my drug, and this is my computer screen, or my paper chart. I want you to hold that medication right up next to that order on the MAR and make sure it matches. And what do you think I'm reading on this label? I'm reading the drug name. I'm reading the dose. I'm reading the expiration date. One time my students and I found that all medications were expired in the drawer. You're reading everything on that label to make sure you've got the right medication. Okay, that's check 1. Check 2, before you put it in the medicine cup, or, after you draw it up in the syringe, you're going to save that, and you're going to read all that again. You don't look at just the syringe. You look at everything. You read this label out of whatever you drew that medicine out of. That's second. And then the 3rd check is right at that patient's bedside, right before it goes in his pie hole, or before you stick them or whatever. You look at that vial or whatever you drew that medication out of, the wrapper, and you read it again. Why do you think we have 3 checks? Because maybe they have but looked at the first check. They were just going by the color code. 2nd check, they just kind of did the same thing. 3rd check, they said, well, you know what, I better read this label. And it's like, holy crap, I'm about to give the wrong medicine. you've gotta read that label to do it 3 times. We already talked about checking allergies, identifiers. What if the patient says, "Whoo, honey, I don't take that medicine. I've never taken that medicine. What is that?" That's a red flag. You don't say, "Well, honey, it's ordered for you, so open up, because I gotta go. Gotta go see my next patient." Swallow. That's a red flag. Go double check and validate that yes, you indeed are supposed to be giving that medicine to that patient. Because a lot of these patients, they know what they're supposed to get. Now some of them, they don't have a clue. I asked my wife, I don't know what I take. You know, but some patients do, and if they question you, stop. You know, it may be that they're supposed to get it, but yeah. We'll talk about wasted medicine. And here we go. Okay, here's our first check again. Here it is. Check 1. When we get it from wherever we get it. Okay? Do y'all know what this is?
Omnicell.
It's an Omnicell is a name brand, or a Pyxis, or whatever. It's like an ATM for drugs. And they're on the floor. So I need to give this to my patient. So here I go. This is me, but not really. I put my fingerprint right here, and it knows it's me. It knows that's Deborah Swansea when I put my finger right there. And then my list of patients is going to come up, and I'm going to click that one right there. Boop. And all their list of medicines is going to come up that has been validated. And say it's Lasix 40 milligrams I need to give, which is furosemide. This drawer is going to pop open. And this little thing right here is going to pop up. You can't open these, okay? I have to punch Lasix here, and the Lasix drawer opens up. And I reach in there and grab it. And there's pills in there. And they're not just thrown in there. They're in a little wrapper called a unit dose. And I'm going to pick that up. What am I going to do? I'm going to hold it where she's holding her finger. I'm going to compare it and make sure I've got the right drug. I've seen nurses reach in that drawer. It's the Lasix drawer, right? Just get it and put it in the thing without reading the label, because it's in the Lasix drawer, right? Who put it in there?
Pharmacy, but someone could have returned the med and put it in the wrong drawer.
Exactly. Pharmacy tech. A pharmacy tech put it in there. Somebody trained on. What I'm trying to get to you is people to put it in there. Is anybody perfect? No. So could somebody have put it in the wrong drawer? Read the label. Okay, check 1. That was it. Y'all are going to see this in the hospital too. This is called, we used to call them cows. Computer on wheels. Some people said, oh, that's offensive to say a cow. So now you can say it's a WOW, a workstation on wheels. I don't really care what you call it. But this would be mine, my personal one. And these are all the drawers that belong to my patients. Each patient's labeled, you know, with their date, their MR number and all that. Somebody might have come in early and stocked all my drawers for me with my patient's medicines. Or maybe I stocked all my drawers. So in that case, that would be my first check when I take it out of that little drawer right there. Okay? So when's the first check happen? When it comes out of wherever it is. Okay? It may be in a pneumatic tube, like at the bank, that the pharmacy sends up. That would be your first check, you know, whenever you get that medicine. Y'all know medicines have a bunch of names. You're not going to be responsible ever for knowing the chemical name, like this for Tylenol, N-acetylparabenecol. We don't care that you know that. But many times you'll need to know the generic and the trade name for medication. So y'all know the generic name for Tylenol is acetaminophen. Trade name is given by the company that makes Tylenol. Okay, and so when it's a trade name, you'll see this, okay? The little TM, and usually it starts with a capital letter, and a generic starts with a lowercase letter. We do ask you to know both as a student. Okay? Like I kept saying Lasix, y'all, that's a trade name. The generic name is furosemide. So, yeah. And a lot of these are look-alike, sound-alike too. Here's check 2. What was check 1? I forgot. When you get it, out of wherever it is. Here's check 2. When I take that medicine in that unit dose package, and I put it in the cup. Let me ask you this question. Do I open this package and put the pill in the cup, or do I put the package in the cup? Package in the cup. Don't open it till you get to the bedside, okay? So this is called a souffle cup. It only holds a couple of pills. There's some plastic ones that are bigger that could hold. Some patients are on a lot of medicine, okay? Or maybe I drew something up in a syringe. In that case, I'm going to save the vial that I drew it out of, and I'm going to label my syringe. And y'all are all going to give parenteral medications, which means a needle, and you will label your syringe. So that's check 2. Now, every single time, I'm reading the label. And not only am I reading it, I'm comparing it to what? The mark. And what am I reading on here? The name of the medicine. And I'm going to check the dose. I'm going to check the expiration. I'm going to check the time. Everything. Every time. This gets old, doesn't it? No, it doesn't. Because it's going to keep you from making a medication error and keep your patient safe. Third check. Here it is. He's so happy. You're giving him his medicine, but she said, What's she doing? She's checking his armband, and she's gonna see these are unwrapped, but you don't unwrap them until you're ready to give them to the patient. Many times it's gonna be compared to the mark, read it again, open it. Mr. Mann, this is your furosemide or Lasix. I'm giving this to you for your blood pressure today. It's going to make you use their vocabulary. They say urinate, you say urinate. They say pee, whatever. It's going to make you pee a lot. And you might get lightheaded. Call me before you get up to go to the bathroom. You're teaching with every medicine that you give that patient. Some patients, they may say, you know what? Tell me what I'm taking. Open every one of them up, and they're just going to throw back and swallow 20 pills. Some people do that, but don't assume they're going to do that, because you can open them all up and they'll say, honey, you know what, I'm going to take everything but my diuretic today. And you've opened them all up and you don't know what's what. So you have to be careful with that. Okay, when are they? What's the first check? Wait, what do we do with our, before we even start? We've got a new order. Verify the order. And then after that, we're good to go. What's the first check? You're getting it out of wherever. Second check?
Before you put it in your, before you put it.
And you put it in that little cup or draw it up or whatever. And third check? What about before or after you give it to the patient?
Before.
Before is good. Oh, there's morphine. Can y'all give morphine to students? Yes. Yes, you can. Are we going to sit there and you by yourself to do it? No. But you can give narcotics as students, okay? A couple of things you can't give. You can't give chemo. You can't give IV chemo. You can't give blood. IV Dilantin. But you can give morphine and Dilaudid and all that mess, okay? You got to be careful. And we're right behind you. Helicopter. All right. So tell me about narcotics. Do y'all remember that Omnicell or Pyxis that I showed you? Narcotics are in there too, but it's going to be different.
They require a second.
So when I click punch morphine, it's going to ask me, how many morphines are in that drawer? And I have to count them and type in the number. If that number doesn't match what's in that drawer, sirens start going off. Not really, but an investigation happens, because if there's supposed to be 9 in that drawer and then there's 8, my narcotic count is off, okay? And it has to be investigated. So that has to match every time. Okay. okay, how much, okay, so my patient has an order to get 5 milligrams of morphine based on this vial right here. How much am I gonna give him in volume? Half a milliliter. Good. All right, what am I gonna do with that other half milliliter? What am I gonna do with that other half milliliter? Right, okay. So in this vial, I have to draw every bit of it up. I'm gonna draw up the whole 10 milligrams, but I'm only gonna give my patient 5. So I'm gonna have somebody come with me,
Verify.
and I'm gonna scan my badge. Boop, and I'm gonna scan her badge, and now she's watching me waste this morphine. And how do I waste it? I'm gonna squirt it out wherever my hospital says squirt it out, in the sink, in a special box, or whatever. I'm gonna squirt it out, and she's gonna say, yes, I saw her waste 5 milligrams of morphine. You have to have somebody watch you waste a narcotic. Okay. What if it's a pill, like a half of a PO tablet? You think you can just throw the other half away? Then you gotta crush that puppy up and all that stuff, okay? This is just a tamper, this is dilaudid, and like it has labels, and you can tell if it's been tampered with or twisted or something like that. Y'all, do you think nurses might sometimes get a hold of narcotics that they shouldn't? Like I could say I was giving my patient 5 milligrams of morphine and give him half a milliliter of saline, right? I mean, our profession is one of integrity. You're trusted with a lot of medications, and you can get your hands on them. I already talked about education. I talked about assessment, didn't I? Like if you're giving something nephrotoxic, we hadn't talked about kidney labs yet in patho. I'm your kidney person. We'll check kidney labs. We check the labs that are appropriate for the medication that we're giving. Are we doing assessment? Like there's a medication we give, a beta blocker or DIG or something that lowers your heart rate. Well, honey, I'm not going to give it to you if your heart rate's 20. You know, so I have to do a pre-assessment to make sure I'm safe. And then your patient can do this. No, I'm not taking it. What do you do then? You document it. I mean, you educate them and you try to get them to take their medicine. Of course, first you got a red flag. Make sure they're supposed to have it. And then you document that they refuse to take it. And then it's like, well, why are you in the hospital if you're not going to take your medicine? But sometimes people do refuse to take their medicine. I already told you you can't give chemo. Maybe you might can give PO chemo. Because a lot of chemo is PO now, some of it, and some of it is IV. Very, you have to be certified to, not every RN can give chemo IV. You have to be certified to give it. And it has to be mixed in a special place, and you have to wear all this protective equipment, okay? But even PO chemo, oral chemo, you have to wear gloves that are made for that, or double glove. You have to teach the patient taking it at home that it can be excreted in their urine or whatever, double flushing their toilets. You can get the same effects from oral chemo, bad effects to you that you can from IV chemo. So it's a dangerous thing to give. It attacks rapidly dividing cells. And so we want to be real careful with that. Don't crush, cut, or split any kind of chemotherapy drug. That means taking that pill and crushing it up so they can swallow it better. No, because you're going to be exposing yourself to toxins. You'll have a spill policy at your place. If you do get some on your clothes, you wash them twice in hot water. You don't wash them with any other clothes. So there are a lot of precautions with chemotherapy. That's why students don't give it. All right, that was the right drug. We can do right time before a break. We've done right patient, right drug. That's the right drug is the longest one. Right time. And listen, if you make a mistake in any of these 7 rights, it's a medication error. And then what do you do? If you make other than vomit, what do you do if you make a medication error? What do you think's your first priority? Assess the patient. Assess the patient first. That's your first priority. And then you would let somebody know and you would write an incident report. And that goes to risk management. Do you say in the chart that you wrote an incident report? No. You could state the fact, medication given at 12 o'clock. You don't say given at 12 o'clock instead of 10 o'clock. Error made. You just state the facts, and then you would state the condition of the patient. Okay, right time. Military time is what we use. We didn't used to. Why do you think we had to go to military time? Errors being made. So y'all pretty much y'all know military time. Okay, so we have to do that. And many agencies have schedules, like something that's ordered QAM every morning. Many agencies, that's 9 o'clock. 9 o'clock mid. TID, which is 3 times a day. Is TID and Q8 hours the same thing? TID 3 times a day and every 8 hours. Is that the same?
No.
It's not. TID means 3 times a day. It's usually during waking hours, like
With their meals.
9, 1, and 5. Q8 hours is every 8 hours around the clock. And nurses can manipulate the time too if they feel like, they need to be therapeutic with a sleep medication or whatever. Okay, standing order, we give it until it's discontinued. That's the standing order. Like we verified it and we're going to give it until it's discontinued. PRN. A lot of our medications are ordered PRN. What does that mean? As needed. So morphine, typically, that morphine 4 milligrams IV PRN for pain. When do I get it? As needed, but not any more often than 4 hours, right? If it's ordered Q4 PRN, then I can get it if I need it, but not any sooner than 4 hours. Now, what if my patient is not relieved from that pain in 4 hours? Do I just not worry about it? No, I gotta call somebody about it, okay? Single one time might be, give her a flu shot before she's discharged. Give her some kind of vaccine before she's shingles vaccine before one time dose, or give them a gram of Ancef IV on call to OR, something like that. One time, you give it one time. Stat means drop what you're doing and go give it right now. That's an emergency, like could be a life-saving measure. Stat means go do it right now. Now, on the other hand, is not stat. Now means usually it's within 90 minutes. Because in a hospital time, 90 minutes is like a second, okay? Time flies so fast. So that means try to get it as quick as you can, but it's not like a stat that you don't plan with, okay? Ooh, this is important. Before we go to break, y'all, this is real important. Remember I said that QAM drugs are usually at 9. Okay, well I've got 6 patients, and they've all got 9 o'clock drugs ordered. Is everybody gonna be laying there at 9 o'clock? Like this, and I just pop it in before the clock beams 9? No, I have to decide, okay, what's the most important thing here? Does it matter what time I give this one? So you've got time-sensitive drugs and you've got drugs that are not so time-sensitive. For example, an antibiotic, typically you have to maintain a blood level, and then IV antibiotic. So things that are critical like that, you have a 30-minute window. And what that means is if it's ordered for 9, You can give it anywhere from 8:30 to 9:30. You've got 30 minutes on each side of it, okay? That's things like antibiotics, it could be anticoagulants, anything that we have to maintain a therapeutic blood level. Insulin, things like that. Critical. Now, a vitamin. I mean, is anything gonna happen bad to me if I don't get my vitamin right at 9 o'clock? No. So many times, an agency will give you 1 to 2 hours on each side. So say your agency gives you 2 hours on each side and it's ordered at 9. I can give it anywhere from 7 till 11. So I've got some good window for that. And I won't be considered late. I've got 4 hours to give it, right? So you've got windows on each side. So make sure you're aware of this, okay? So as a nurse, you'll have to look at your patients, and I like to be orderly, so I'd be wanting to give it to my patients rooms 1 through 6 in order, but I might not be able to do that, huh? Because what if room 3 is the one with the time-sensitive medication? So I've got to look at all my meds and plan it out. Got to go see this one, and this is the order I'm going to see it. So that's more critical thinking you have to do. Okay. Y'all take a break, and then we'll dose when you get back. You got to come back because we've only done 3 rights. Which ones have we done? Dose. Mercy, there's so much to do. So we talked about the unit dose, the little medications are wrapped individually. And it's usual doses. Like I keep talking about furosemide, and we're very familiar with it. It's a diuretic. It's usually a 20, 40, 80, or 100 milligram tablets. And so those are usual doses. And that's a safe way to do things. So unit dose is one way that we can be careful with our dose. If you have to has everybody made 100 on every single math test? Every single one with never a mistake ever. Okay, that's why we want to verify calculations, especially high alert things like insulin and some anticoagulants. Some hospitals require double checks on IV digoxin or whatever. You'll know, but most agencies require a double check on things like insulin. So verify calculations, and also this. Like I drew up the insulin, I drew it out of here, I drew it up, here's my syringe, and now what I have to do is go, boop, boop. I scan her badge and she double checks it.
Looks good.
And she looks on the MAR too, and you have to have 2 RNs typically sign off on giving insulin. Okay, high alert drugs, we want to make sure our dose is right. We measure it in syringe. This is a syringe for oral use. This is that wrapped container I've been talking about. IV medication, etc. I showed y'all the cups. And we want to avoid pouring. You won't see many things that you have to actually pour into a cup to measure. You may still, and you want to hold it up at eye level, but most of the time now it's in like a foil container, and it's already pre-measured, again, to try to make sure that we don't make dosage errors. Oh, let's talk about splitting pills. Cutting or splitting pills. Can you cut and split any pill? No, you can't do chemo for sure. So this is what it means when a pill is scored. See? You can break it or use a pill cutter to cut it. You can only do that with scored tablets, okay? Make sure you know that. A lot of hospitals will have the pharmacy go ahead and break it and send it up already broken. That's just another way to maintain safety. What about crushing? Is it all right to crush medicine? Certain ones, you can't crush everything, like if it's extended release. If you crush it, it's immediate release. Or if it's enteric coated, which means that it's coated to get past the stomach and you crush it, it's going to get disintegrated in the stomach and they're not going to get their medicine. There are do not crush lists, and you can always look it up and call the pharmacy to see if it's okay to crush that medicine. Y'all, this is a pill crusher. They all look different. This is what we have at USA. So you take this little blue top off, you put the medicine in here, and then you screw this top down really, 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 really tight, and it makes the medicine turn into a powder. And then you can give it. Mix it in with water and give it. This needs to be cleaned out in between. I can't stand to go in there and find leftover medicine in those, but it usually is. So they need to be cleaned out in between. What does sublingual mean? Under your tongue. You don't crush that. You put it under the tongue. And like I could open this capsule like that and mix it in something, but I can't crush all these little beads. You don't do that. Okay? Syringes. Y'all, see how you can screw a needle onto here? That's called a lure lock. This is a straight tip where a needle just sits on it. Okay? There are all kinds of syringes, and we're going to go in detail on syringes when y'all come to lab next week. So make sure you watch the video that I did and look at the supplies that I have posted and the MAR and label your vials and all that mess before you come to lab. Bring your MAR, bring your armbands. I've got a ton of stuff for you to bring to be ready for lab. So we're going to walk through the whole medication administration process. All right, students. Always want to measure from maybe not the right spot. A lot of students want to measure from this point. So this thing right here is called the plunger. You really shouldn't touch that. And this is the tip of the plunger, so a rubber stopper type thing. Where this thing touches the side is where you measure, okay? We have lots of students that want to measure from this point or from the back of the plunger. But you're going to measure where it hits the side, okay? Make sure you know that. And we'll be doing it in lab, and you'll see how to do it. And you'll get to practice it, and we'll check it to make sure it's right. Okay. Right dose. We're on right route already. Pretty good. Okay. Y'all, if you have an orifice in your body, we can give a medicine in it. Or we can make some. We can make a hole in you with a needle, right? So we're going to talk about how to do that. I'm not going to go in detail on every single route. You can go look in your book, and there are little short videos too. But can you change the route if you say, you know what, I would rather give this IV than PO? Can a nurse decide that? No, you have to ask, and it has to be a written order for you to change the route. You can't just decide you want to do it that way. All right, oral, easiest, easy. The person swallows it. But is it always easy? What if they've had a stroke? What if they can't swallow? What if? They're not conscious. Don't go put pills in somebody's mouth that's not conscious. Okay, that's dangerous. So you have to know, where is it going to be absorbed? Do you give it with food? Do you make sure it's on an empty stomach? There are some medicines you have to give them on an empty stomach if they don't work. Some of them have to be given with food, so you have to know. This extended release, enteric coated, we've talked about that. Y'all said you knew what sublingual was. What's buccal? In your cheek. Just a pinch between your cheek and gum. That's the Skull commercial, I think. And then teach back, the patient does. But watch your little videos in the book, okay? Y'all, this is considered oral too. This is enteral feeding. So your patient is unconscious, and they've got a feeding tube going either through their nose or through a PEG tube, percutaneous endoscopic gastrostomy tube. We'll worry about that later. But we can give medicines through those tubes. It's best if they're in a liquid form, but we may have to crush them and mix them in with water and make sure they're real dissolved. Because everybody hates you if you clog up a feeding tube, okay? Especially your patient. So before we give medicine through a feeding tube, we want to verify placement. We want to make sure that that tube is in the right place. And where is the right place? Their stomach or their, duodenum or whatever. We don't want it in the lungs. Could it migrate to the lungs, and have I seen it migrate to the lungs? Yes, so what if I blasted some medicine into their lungs? Horrible idea. They've aspirated and they can get pneumonia. They really could die from that. So this is another thing too. Remember we talked about this morning in patho, if you've got an NG tube to suction, don't give them medicine in the NG tube that's to suction, because what's going to happen? It's going to suck it right back out. So you don't do that, okay? You want to elevate their head. You're going to check residual. And what that means is you get a big old syringe like this. You hook it onto the NG tube. And you pull back. You pull back. And you squirt it into something. And you pull some more back. Squirt it into something. And you see how much residual is just hanging out in the stomach. If it's greater than, what does that say up there? 500 milliliters? What do you think? They probably are not tolerating, they're not absorbing their medication. It's really, really important that all that really vomit that you just took out of them, if it's 500 or less, you put it right back in. Squirt it right back in. Why? Because they might have a metabolic alkalosis, right? Or they may have a fluid and electrolyte imbalance. They get that back. Even though it sounds really gross to put it back, you do. And you want to flush the tube with water. Topical. You put it on their skin. Ointment, lotion, cream, paste, etc. Clean the skin first. Take the old patch off before you put the new patch on. What patch do you think you're going to see in the hospital? Everybody's got a nicotine patch, it seems like. You've got to take the old one off before you put the new one on and put it in a clean, new spot. Oh, we put stuff in people's eyes. It's called optic or ophthalmic. And this is how you do it. You put it in the lower conjunctival sac. You hold pressure right here. If you feel like it could have systemic effects. And there you go. Y'all just... I'm not going to read this PowerPoint to you, but you do need to know how to give things in people's eyes. Have y'all done examinations of the ears yet and assessments? So y'all already know this, don't you? Same thing. Adult, pull up and back. Kids, down, right? To get those drops in their ear. So if you gave me drops in my right ear, what side do you want to tell me to lay on for a little while? Yeah, my left side. Don't occlude the ear canal. Make sure the drops are sterile. You don't want to give them freezing cold. They want to be room temperature, etc. We can give nasal things, and I'm not going to spend a lot of time on this one. We can give sprays. We can give inhalers, and they're all different kinds. Who do you think is going to get an inhaler type medication? Somebody with asthma might get that. Maybe some kind of a bronchodilator to give them. So every one of them is pretty much going to have a different set of instructions, so you're not going to be required to know that for this class, okay? Oh my goodness, let's see, we can give things in the vagina too. So with a gloved hand, you can get it put it in with your finger, and you can see here that you would go 3 to 4 inches, and I just kind of say, that's pretty much all the way to victory, you know. So, or you can do it with an applicator, and you want to lubricate it It's a very private thing. Vaginal suppositories can be pretty large. We keep them in the refrigerator. And I always tell this story because students are nervous about not so much vaginal but rectal suppositories. And they'll carry that thing around and they'll sweat and worry. And by the time we go in there to give it, it's melted. You know? So they do melt. So if I gave this, if I gave this to her, what might I tell her to do for a little while? Maybe stay laying down for a little while. Not go walking down the hall. What's going to happen? It's going to fall out. Okay. We can give things rectally. Wear gloves for that too. I hope. If there's a whole clump of poo-poo there, fecal material, you don't force the medicine into that. Again, all the way to victory. And it's a shorter distance than infants. Use lubrication, turn them on their side, on their left side preferably. Y'all, this is embarrassing to people. We kind of laugh about it. It's fun, it kind of can be, but it's embarrassing to people. So maintain their privacy and that sort of thing. I love to give rectal Tylenol. It works so good. It just works good. But can I decide that? I have to ask. You'll get used to it. You'll be going in there before you know it, it's going. Okay, parenteral. Did y'all know y'all were going to be doing that kind of stuff to people? Hey, be sure you tell them, like I said, go ask that man if he's going to take this suppository. Student goes in there, you're going to take the suppository, yeah, we go get it out of the Pyxis, we go do all the stuff, sign it out. We go in there, the student unwraps it, and the man goes, what's that? I said, it's your suppository. He said, where are you going to put that? He said, in your rectum. He said, no, you know. He didn't know what a suppository was. The man. He said, you ain't putting that in there. So we had to go away, put it back. Okay. All right, parenteral means we're going to stick you. Okay? We're going to stick you. We're going to do an intradermal, which is this. And so y'all need to know the angles, okay? And it's on your guide that I made you right here, and it's in your book. So this is the intradermal right below the dermis. Subcutaneous is this, right, into that little subcu fat right there. You can give it at a 90-degree angle or a 45, depending on the size of your patient. And then intramuscular, we abbreviate that IM, and it goes into the muscle. So which one needs a longer needle? There you go. And then IV, of course. And this is a sterile procedure. Are you wearing sterile gloves? No. You're not wearing sterile gloves, but you're not touching the needle, you're not touching the plunger, you're cleaning the patient's skin and all that. We're going to handle this.
What's the degree for IV?
You give it into the IV tubing. Oh, okay. Yeah. So this is a vial. It's glass. When this little top pops off, it's game over. It doesn't go back on. Some of these are multi-dose, which means you can have, draw several doses out. You don't have to throw it away like insulin. Sometimes can be multi-dose. This is an ampule. You have these in your bag wrapped up in bubble wrap, and they're made out of glass, and we pop the little neck and get the medicine out, and we'll do that in the lab. You have to use a filter needle to draw it out of that glass. What do you think?
The shards of glass.
Yeah, it keeps the glass from being, okay? And then we change the needle. Because if you've got a filter needle, I can't remember, I think yours is in a pink little case, but bring all that stuff. Syringes and needles. Okay, this is weird, kind of like if you have a lot of hydrogen, your pH is low. Well, this is kind of another weird thing. The smaller the number, the larger the needle is around. So a 16 gauge is like a nail, and a 20 gauge is a little bit smaller. 25 gauge is even really thin, 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 thin. So just remember that principle, okay? The smaller the gauge number, the fatter around that needle is. Who decides what size needle to use? The nurse. It's your clinical judgment. So you don't go pick a gigantic needle if you don't like your patient, right? You do it by, and they're color coded too, like a pink is usually 20 for IVs and everything. Y'all need to know the parts of a needle. This is the hub, the shaft, and the bevel. The bevel's that angle. And so in lab, we'll be talking about, put this in, bevel up, or whatever. We'll be talking about the bevel. It's sharp and it makes it go in good. Don't you want your needle sharp if you're getting a shot? Me too. So how do you decide how long of a needle? Well, how large is your patient? And am I trying to go to the sub-Q layer? Am I trying to go to the muscle? And if I've got somebody with an arm that's larger, then I'm going to have to get a 1.5 or 2 inch needle to get there. So that's my clinical judgment. Gauge, how fat around it is, really depends a lot on how thick the medicine is that I have to draw up, like the viscosity of the medicine. If you've ever seen, probably hadn't, but Ativan, that I talked about earlier, that you can have an idiosyncratic reaction, it's like drawing up honey. It's so thick, and so you need a big gauge. There it is again, same thing. Okay, here we go with intradermal. This is what you'll study, okay? Tells you what angle, what is intradermal. Well, your TB skin test that y'all got, right? And this is the one you're going to go bevel up, because when you insert it, you want to get that little bleb right there. So does that make sense that you want the bevel up to get the medicine, where you could make that little, it's called a bleb. And so this gives you the needle sizes. I will tell you this, for 311, I'll be posting what medicine you're going to give for your checkoff. But a lot of the needles on your insulin syringes and your TB syringes, they're already pre-attached. You can't get them. So they're already there for you. And they're really thin, little tiny gauge, almost like hair. They'll bend easy because they're so skinny of a gauge. These are the places you can give subcutaneous. It's absorbed best in the abdomen. We can give it behind the arms. It's kind of absorbed slowest in the thigh area. But these are where you give it. The rule of thumb is if I can pinch up, like this. 2 inches of tissue, go at a 90, most of us could pinch up at least 1 inch on our abdomen. 2 inches, 90 degrees, 1 inch, 45 degrees to make sure we're hitting that subcutaneous tissue. It's not vascular. We don't aspirate with a sub-Q, meaning this is aspirate. You stick the needle in, and then you pull back on the plunger, and you're hoping to not see blood. If you see blood when you aspirate, what does that mean? You're in a blood vessel. And so, well, let's think about this. What if I did aspirate and there was blood? What do I do? Take it out, throw everything away, and start over. That's what we do. Y'all, this is an insulin syringe. Most of the time they're orange. Can I count on it, Dennis Quaid? No. I'm going to read the package, but they most of the time are orange. And let me tell you what you give in an insulin syringe. Insulin. And what else can you give? Nothing. Nothing. Only insulin in an insulin syringe. So if you get insulin for your checkoff, you get an insulin syringe, okay? Because it's measured in units. This is, see, unit, unit. And your insulin is dosed in units. So you only do insulin, okay? Insulin syringe for insulin. Okay. I told you where it's faster absorbed, pinching, I told you about that. You pinch it, and with insulin, you can release it as you're injecting, that's okay. Don't aspirate and don't massage any of these. None of these parenteral injections, don't massage them, okay? That's damaging. Okay, we gotta learn how to mix insulin, okay? And we're running out of time, so I'm just gonna, you can study this slide, okay? This is cloudy, A, which would be like your NPH insulin, and y'all have some in your bag, okay? And clear is more of a rapid acting. So what you would do is clean the vial and just put air in, but not draw it out. Draw out the clear, and then draw out the cloudy. So here's the moral of the story. You put air in both of them first, and then you draw out the clear first, followed by the cloudy. Okay, so make sure you study that. And listen, I'm going to check it between this and this. You're going to have to check me on my clear, and then I'm going to draw my cloudy in the same syringe. I've got to have you check it. Okay. Heparin. Hey, if you get heparin, some of you will get heparin. Let me tell you what syringe to get. A TB syringe, which is a tuberculin syringe. Typically, they have a brown top, but for some reason, some of yours have a blue top in your bag. But how would you know? You're going to read the label, okay? So this is heparin. It's an anticoagulant. You give it on the right or left side of the belly button or umbilicus, 2 inches. You pinch the skin and you keep it pinched while you're giving it, and you don't massage, okay? And this is a small needle too, and it's the same rule. Pinch 2 inches, 90 degrees, pinch 1 inch, 45 degrees. This is Lovenox, which is a low molecular weight heparin or enoxaparin. And I don't know, can y'all see that bubble right there? That's an air bubble, okay? Most of the time, we say we got to get the air bubbles out of a syringe, not with Lovenox. Once I hold the syringe up like this to dart it in, that air bubble's going to go back here to the back. When I'm holding it up and down, the air bubble goes in last. It chases the medicine in and kind of seals it in. So don't expel the air bubble, okay? Please don't. Okay, IM, intramuscular. We're going to work on locating intramuscular injection sites in the lab next week on the mannequins. You're going to be responsible for this. And for your medication video, you're going to have a real live person that you're showing us their IM injection sites on. Don't take their clothes off or anything like that. But you're going to show us their IM injection site. So go ahead and be finding somebody. A nursing student's a real good somebody to find, because sometimes family members are laughing and carrying on. So these are the sites. This is the preferred site, ventrogluteal, okay? If you get an IM injection, you are going to aspirate. If you don't aspirate, you're going to fail the checkoff, okay? Now, the CDC does say that for flu shots and, tetanus toxoids and stuff like that, we're not aspirating anymore. But until the CDC changes it, your IM injection is morphine and you're going to aspirate. And if you get blood, you're going to throw it away. Okay? We're going to give IM injections with a 3 milliliter syringe. Just grab a 3 milliliter syringe and you'll pick your needle, okay, based on your patient's size, etc. 90-degree angle, all the way to the hub, not halfway hanging out. So you pick the right length and you go all the way to the hub, okay, all the way. Don't leave it hanging out. How many of you have gotten a shot in your butt? Okay, that's not recommended at all anymore. Not at all anymore because of sciatica. Hitting the sciatic nerve, it is not, we don't even teach you how to do it in your book. Have I gotten them in my butt? Yes. But I've also gotten the ventrogluteal that's preferred. Okay? 90 degrees, you try to wait 10 seconds before you take the needle out. This is ventrogluteal. Okay? It's the preferred and safest. Let me show you this. I like this one better. Look, you roll that patient towards you, and we'll talk about the landmarks. But you're given that right in here. It holds more. It's the best preferred site, evidence-based, and less complications. Ventrogluteal. Okay? Has anybody ever gotten a shot there? I have. Vastus lateralis, leg. We're going to show you how to find it. This is easy. You do a hand's breadth above the knee, a hand's breadth below the greater trochanter, and you give it on this little outer portion right here and grab it up. You need to pull that muscle up. Easy to find. We give a lot of kids injections in the vastus lateralis. Can y'all say that, vastus lateralis? That's fun to say. What's cachectic people? Patho people, what's cachexia? All skinny and wasted away. So you may have to grab that muscle and pull it up to get it. Are y'all ready to give shots? Clapping. Deltoid, that's in your arm. We're going to find that in the lab too. Very small volumes. Flu shots and that kind of stuff. We'll talk about how to find it. It's so easy. Y'all might get to do a drive-through flu clinic. They hold their arm out and you just pop it. We did that with COVID drive-through. We gave the COVID drive-through shots and we gave it in their arm. Okay, y'all need to look at Z-Track. Y'all don't have to give your IM injection Z-Track, but it's recommended. So what you do, you can see the picture. You grab the skin and you pull it tight. And while it's still pulled tight, you give the shot and get it in there. And then you kind of keep it pulled tight for 10 seconds or so, and then you let the skin go back over it, and it seals that medication in there, and it doesn't let it leak back into the tissues. And it's really important to do this with medications that are painful, that leak back, or even that can stain the skin. So this is Z-Track. When I give you a shot, do I want to ease it in? I want to dart it in. Dart. Boom. And then get it. We'll do all this in the lab. Bring your little thing, your little square thing to give you. Yep. It's in your blue bag. Square thing. I don't know what it is. Squishy square thing. How can you minimize pain? Well, do it fast. Use the smallest gauge. What's gauge mean? Bat around. Use the smallest gauge possible. That'll work. If you draw up some medication that's painful medication, take that needle off and put a fresh new needle on, right? So that won't irritate the skin. Okay, ampules, we're going to take the stuff out quickly. We've already talked about not letting, all right, so this is a sterile procedure, but we're not wearing sterile gloves. So if we take the cap off of our needle, can I lay it on the countertop? No. So you have to keep that needle covered. You can't touch the end of the syringe. You got to put the needle on aseptically. And we're going to do that together in the lab. How do we clean the skin? Center out. We don't go because we're dragging dirty back over clean. We center out in a little circle. Of course, we're going to wash our hands. We did that already, right? We're going to do it. This is IV medication. Here's your angle. You just put it in the IV tubing. Now, this matters. Not all medicine can be given at the same rate. Some things I have to push over 2 or 3 minutes. Some things I can push right in. How do I know that? I look it up or call the pharmacy. And sometimes, if you give it too fast, like I'm going to furosemide again, you can cause ear damage to people, ototoxicity. So you have to know these things when you're giving your medicine. Very high risk, because once that's put in, girl, it's gone. You can't get it back. Okay, we got to make a pledge together. Y'all, see, what's this right here? Oh. Raise your right hand and repeat after me. I will never, ever, never, ever, recap a used needle. Ever. Amen. I'm going to take that needle after I stick it in that patient, and I'm putting it in that sharps container. Because your patient has HIV, B, C, A, D, E, F, COVID. They've got everything. And then you stick yourself. What? Is that bad? Don't you recap a used needle. Okay? Some of you are going to do it in your checkoff, and it makes me so sad. Are you going to pass?
No.
Do you ever throw your needle in the garbage can?
No.
Do some people?
Yes.
Don't do it. You got to be safe. So we're going to use blunt. This is a safety. See that needle right there? They're pulling up that safety over that needle and clicking it. Your needles don't have safeties, y'all. You got a regular old needle, no safety, because you're reusing your stuff. Okay. Don't you recap that needle. This is a safety. You push that up and it covers the needle. But like I said, yours don't have a safety.
The majority of them have it?
Yeah. In the hospital, they don't have it. But there are going to be cases where you won't. Y'all went out. Things changed. When I was in school, when I was practicing in the ICU, the first ICU I worked at, our policy was recap needles after you use them. I'd be carefully recapping. Guess what? Did I stick myself ever? Yes. Did the patient have HIV? Yes. Did I have to have all the testing and all that? Yes. Don't do it. I found that. All right. Okay. Right, here's another right, y'all, documentation. Right, documentation. We've got to document that we gave that medicine. Don't document you gave it before you give it. And then, like if we gave an IM injection, we're going to document where we gave it. And then if it was a pain medicine, we're going to document, did it work? Okay? Or if they had an adverse drug event, we got to document that. Don't ever try to give medicine from an order that you can't read. They have to have all the parts. Here's a good, I must love furosemide. Jaguar Jones, furosemide, 40 milligrams, PO, every 4 hours. It's got to have all the parts. If it doesn't, I can't give it. Okay, said all that. Are you ever going to have to call somebody in the middle of the night, 2 o'clock in the morning? Can you get a verbal order as a nurse? A phone order? Yeah. Look, you got to read it back. You just woke somebody at 2 o'clock in the morning up and told them all this stuff and that you need something, and they gave you an order. Read it back to them. Could you say something crazy at 2 o'clock in the morning? Yeah. Some hospitals make 2 nurses be on the phone to listen and make sure that that telephone order is right. A verbal order, on the other hand, is a healthcare provider comes in the room and I'm standing there and he says, hey, give Miss so-and-so lady down the hall this and that, this and that. And I'm supposed to write it down. No. We used to do that all the time. Now it's like, I tell you what, you go ahead and write that order down for me, and then I'll do it. So verbal orders should really just happen in emergency situations. And if you do have to write one, you write VO, D Swansea RN or whatever, and VO, healthcare provider's name, Dr. McDreamy or whatever. And then my name, and then he has to, or she has to co-sign it when they come back the next day. Here's how you sign your stuff, y'all. This is what you are. You're going to sign your name, whatever it is, USA, SN. Because there are lots of SNs around. Coastal, Auburn comes down here of all things, all kinds of people. What else do I want to, as a student nurse, can you call a physician or take a verbal order? No. You just play dumb and say, you know, I can't do it. Let me go get my instructor. And you just get out of there. There is a do not use list for abbreviations. Make sure you're familiar with the TJC do not use list. You have to be careful with abbreviations. Morphine's one thing we don't abbreviate. We used to, MSO4. I can't tell you how many times I've written MSO4. Well, that got mixed up with morphine, magnesium citrate, all kinds of stuff. So it has to be written out now. This is the TJC don't use list. Do not use list. You have to know this. So, yeah, no. We don't write U for, we used to write just 10U for insulin. I've taken a million verbal orders. We don't do that really anymore. U. It has to be written out. Units. Because we were making mistakes. And y'all know about trailing zeros and all that from math. I've already said this. If you make an error, your first priority is to make sure your patient's safe. Then you call somebody, let them know, make an incident report and all, and you don't put it in the chart. Right indication, the last right. What are they again? Right. Patient, drug, time, dose, route, documentation, indication. Indication means, is this even a thing for this patient to give this medicine? Do we give this to patients with heart failure? I mean, why are we giving it? So in your case, if you're giving heparin to your patient for your video, you'll say the right indication is for anticoagulation. You know, that's why we're giving it. We're trying to prevent a DVT or whatever. You know, we're trying to anticoagulate this patient. We're giving insulin, the patient's diabetic, we're trying to control their blood sugars. We're giving morphine, it's an opioid analgesic, it's for pain control. I mean, it helps us. Y'all, do you follow the rights every time?
Yes.
Every time. Y'all, I can't tell you how many students fail their medication check-off. Because they'll do all 7 one time, and then the next time they'll do just a few, and they won't even look at the label. They'll just maybe look at the syringe and say, I checked it. You're not checking it if you're not looking at the label of the container and the syringe every single time. So you'll say all 7 rights every single time. Documentation, patient, all that. Y'all, you got to be free from distractions. How many times are we going to compare it to tomorrow? If you forget where you are, do it again. Do it again. Double check calculations. Oh, I love this one. Question unusually large or small doses. One time I was helping a student do insulin, and you know it's a teeny tiny dose. And they said, this syringe isn't big enough. I said, oh. What you want? I went and got a 10 milliliter, not big enough. 60 milliliter syringe, I went and got that. That's what they want. Y'all, that will kill somebody. Or if you do a calculation and it says you need to give 275 tablets, that's wrong. You calculated wrong. So question unusually large or small doses. Hang on, y'all. Let me see if there's anything else. We talked about workarounds. And if errors keep happening, the same one, there's something wrong with the system or the way we're doing things. That's why we report them. Y'all are making me nervous packing up your bags. It's time to go, though. Y'all have any questions? It's 5 minutes over, I'm sorry. Y'all have any questions? Y'all wouldn't dare ask a question, would you? And you'd probably slap somebody that did ask a question.